All right, good afternoon, everyone, and welcome to Multi-Modality Imaging Conference. Today, we're going to be talking about cardiovascular PET, basic principles, and current applications. I'm Mouaz Al-Mallah, and I'm going to be talking about this important topic of cardiovascular PET. We're streaming live on social media and YouTube and Twitter and other venues. If you would like to ask a question, please send a text message, text DeBakey to 37607, and we can get your questions and answer them after the lecture part. Okay, so we're gonna cover cardiovascular PET basic principles. So far you've heard about the basic principles of multiple imaging modalities, including echo from Dr. Zogby and CT from Dr. Cheng, and last week Dr. Mamarian covered SPECT. So we're going to be moving now. In PET, we talk about both PET and CT, and we're going to show you how we integrate both modalities in doing cardiovascular PET CT. So let's start with the anatomy. So all our scanners, at least the ones that we have here at Methodist, are PET CT. So we're going to show you how we integrate both of them. So just as a contrast, this is how a SPECT CT that we have in Foundry 9 and our building here are. So you have the SPECT machines, the SPECT detectors that Dr. Mamarian covered last week. And behind them, you have the CT machine. And this is how the two heads roll around the patient when you are imaging the patient. In contrast, this is how a PET CT machine looks like, and this is the Siemens Vision that we have in our lab here. And in the front is the CT part, and the back is the PET part. And I'm going to show you another one from a different vendor. This is from GE, and this is a GE Discovery 690 that I worked with for some time. And if you open up these nice coverings, and this is how the machine looks from inside. So if you are in a place where they are installing a PET CT, this is how the machine is brought in on site. We're going to dig deep into the anatomy of this machine. So if you look here, you have the PET detectors here, the different rows. So I'm going to just quickly zoom on them, and you'll see different rows here of the PET machine. So each one of them is a different PET unit, PET detectors, and I'm going to take you through depth of each one of them, what's behind these PET units. And each one of these, they usually call them rings in the PET industry. So what's inside each ring of PET detectors that you have here? So what you have are the scintillators or the detectors. You have the multi-crystal detector eventually. You have the PMT or photomultiplier tube, which is very similar to SPECT that you have on the SPECT machines, and the electronics, and then finally are put in rings here. So let's start with the detectors. So what are these detectors? What you have are, let's see, you have the detector, photomultiplier tube, the electronics, and then the electronics connect to the machine here. In PET compared to SPECT, we don't just have them as I showed you in the first figure, where you just have it in the front of the patient. Now you have a full ring of detectors that are in full 360 degrees around the patient. So the first thing that we're going to cover are the detectors, then we just go ahead to the photomultiplier tubes. These are the different material that we make our PET detectors from. The first one I just put for comparison are the SPECT one, which is mostly sodium iodide. Now there are solid state detectors or CZT, but they're not on this table. On PET, most of them are now using the LSO or the lutetium based. There is also the BGO ones, which are mostly the older ones if you have it on the different systems. And the main thing is that the decay of the LYSO or LSO is much slower, so now you have more stable detector and you capture more of the light that you get in there. Now, so when the patient is there and you get the gamma photon, and we'll talk a little bit more later about what is this gamma photon doing. So it will come here and it will hit the detector and start a light photon. And then you can take it there and take it to the next step, which is within that photomultiplier tube to get that light photon and build it up more inside the tube in there. So there is one difference between the different systems, which is these gamma photons are going to come and hit the detector, but they could come from different angles. So that's why some of them have the 2D septi, where it's only going to come and hit the detector if it is coming perpendicular at it. If it comes at an angle, it's not gonna trigger a photon from the detector. And this is why these systems were gonna require a lot of radiation, but they are more sensitive because, they are less sensitive, but they are more accurate because it's gonna be more coming from the heart itself. However, if you take out these lead septae out, now you have more sensitive system, but you need to have more electronic ability to go ahead and separate what's coming from the heart versus what's coming from different organs. So the reasons for 3D are higher sensitivity, lower radiation dose, and lower radiation exposure. However, you need to separate what's accurately coming from the heart versus what's coming from other tissue, which is causing a lot of background. So you need to separate what we call the randoms from the truths, or the random photons that are coming in from the true photons that are coming from the heart. And that's why you have a higher background noise, and you need to have accurate electronics to allow you to separate what's noise and what's true event there. Now the good news is that now most of the newer systems have these electronics, and all our systems now are 3D. So we've moved on to the 3D systems to allow us for accurate image acquisition, and we have the electronics that will separate what is random and what's true in there. So let's move on to the photomultiplier tube, and you heard from Dr. Mamarian last week about the same concept. So in SPECT you have sodium iodide, and then you have the photomultiplier tube. In PET you have the LSO detector and then the photomultiplier tube. And this representation shows you it's confirmed the name. So when you get an event, it goes inside the photomultiplier tube as one ray, and now it's just multiplied into multiple layers. So you think of it as a set of mirrors that will just transmit this light and now magnify it. So for one photon, now you have multiple photons inside, and now you have the ability to go ahead and see the multiple photons and have the ability to get multiple signals for this patient. Now this is done usually by photomultiplier tubes, but now we have electronics that even the photomultiplier tube has moved on to the SPIM. It's becoming electronic, and that's the main basis of the electronic or digital PET-CT, where you have the crystal, you put them multiple clusters together, so you get one block, then you get multiple blocks together. So what you saw in the initial image is these blocks are a full group of these different crystals, and then on top of these are, now we have the digital system, and now they come into full unit, and now this is what you put around the patient. And now each one of these blocks are going to be taken out, and this detector assembly is going to be moved out and just put around the patient. So this is the traditional one, and this is the digital PMT. And now we just put it all around the patient. So the patient is in the middle, you inject the radiotracer, it ejects the photons, and we'll talk about the two separate photons, but then you now have a full ray around the patient. So it's not only the front, in whichever way these photons are going to go, now they're going to be, there are detectors 360 degrees around the patient, and now we get them. Now the biggest question, how do you know that these photons are coming from the patient and not from the heart versus other organs? So the main thing is that when these photons come, when we're going to talk a little bit about it later with positron emission tomography, you have two photons that come out 180 degrees apart. So now you have with time of flight within picoseconds, now you are able to detect the true events. So they should hit two detectors that are 180 degrees apart within picoseconds, and now you can account for that, and you account for their energy there. So the events are coming in from this within one line within 180 degrees. However, you could get scattered events. So this one, it could be coming from this point, and now one of them traveled this way, one of them traveled that way, and now you hit up within that detector within 180 degrees. So it might give the computer the sense that this is coming from this point, but in reality it's coming from here, and this is one scattered. You might have a random event, two random events, one happening here, one happening here, hitting the two detectors that are 180 degrees. So now you have the electronics within the computer to look within picoseconds to be able to distinguish these scattered events or random events from the true events that are coming here. So this is kind of a little bit dry physics in the beginning, but very important. So for our fellows who come to the scanner, when you look at that, you'll see initially when we inject rubidium, you see a lot of random and scattered events. But then later on, the true events start to dominate, and now you get your image mostly from true events after the peak of rubidium. So you have these detectors here around the patient, and you have to also remember that some of these are traveling through different directions. So some of these will travel short distance to the detector here, while the other one is going to travel a little bit longer distance. So with these traveling, you might lower the energy of these, and for PET you need to have an attenuation corrected image. So it's not a luxury like in SPECT, it's a must in PET. And there are three ways to do the attenuation correction. One of them is by a transmission source. So there will be a source rotating around the patient, and these sources are usually germanium, and they will allow you, or cesium, and then you can get these sources to irradiate the patient and draw an attenuation map. Or the more accurate one, or very fast, and this is what we are using mostly now, at least in our lab, is to use CT attenuation correction. This is very fast, much lower energy, and even lower dose and higher resolution than the other ways of attenuation correction. There are other ways on PET MRs now where they can use magnetic resonance imaging, and they can look at the attenuation maps. So let's go back now to the truths and randoms, and just to cover out all of these. So you have this is another description. The heart is in the middle. You get different truths, but they will be hitting also multiple detectors. So one of them could be going this way, hitting two detectors that are 180 degrees. Another one is going to might hit these two detectors, And this is where the computer system is going to go ahead and take that information and just put it inside and try to create a map of where these photons are coming. And as I said, you have the sensitivity within picosecond to account for all of that information, and now you are able to build it up and get that, build the image up. And once you do it, this is for attenuation correction. Now you can, we usually with CT, we can fuse the images, and now you have the low dose CT, and now you have the PET CT information that you are able to get the information from, where you put both of them in fusion imaging, and now, or hybrid imaging, and now you get the attenuation. You can see where that attenuation corrected image is coming from. So a little bit few words about PET versus SPECT. So hopefully enough of the dry physics. Now we get to the clinical information. So to summarize the differences between PET and SPECT, with PET you have the 511 keV because these photons are coming out at 511. We acquire in list mode acquisition. I'll explain that a little bit later. You have way more counts than what you see in SPECT. We have total study has like almost 35 million counts or even more with the digital PET. With SPECT you have 7 to 10 million counts, so it's a little bit less in terms of counts and a little bit noisy. Spatial resolution, it depends on the, very much depends on which radiotracer you have, but you could be reaching less than 2 to 3 millimeter with let's say F18, while with SPECT you're still gonna be 6 to 10 millimeter as you heard last week. So moving on to the, from the machine now, we talked about the machine, the detector, the photomultiplier, and now we have the digital photomultiplier. We talked about 2D versus 3D. We covered the CT attenuation correction. We covered the full ring that you have around the patient. Now we're going to move on and talk about the radiopharmaceuticals that we inject. With SPECT, we talked that we have technetium-based ones. With PET, we have primarily generator or cyclotron-based. The energy is very different. So you have with SPECT 80 to 140. With PET, we have 511. That's why we have better resolution. The attenuation is more in SPECT, but we have higher energy here, so it's less in PET in terms of attenuation. The half-life, although we're using lower energy in SPECT, the agent's half-life is 6 hours to 72 hours, so the overall radiation is higher in SPECT. While here, since we are using, even though we are using higher energy, we have shorter half-life, so we end up with lower radiation dose, and the study duration is longer, 3 to 4 hours versus almost 30 minutes with PET if you're doing perfusion. And unfortunately with PET, as of now, we're still bound to pharmacologic stress compared to SPECT. We can use pharmacologic and exercise. So looking at the ideal PET tracer, the radiopharmaceutical, ideally, if I ask me what would be an ideal one would be available as unit doses. It has high extraction fraction, which Dr. Mamirian covered. Ideal PET resolution, so we need to have the lower positron range, and we'll cover that. It will allow you to have a rest and exercise imaging. It allow you to quantify blood flow. Unfortunately, such a radiotracer is not available yet. So each radiotracer will have some pluses on some of these, but it will have some minuses on the other ones. So these are the radiotracers that we have, and I'll cover them a little bit in more details. The rubidium and ammonia are the approved one in the United States for perfusion imaging. O15 water is primarily used in the US for research. It's used outside the US for perfusion imaging. And then FDG imaging, F18 base is mostly used for metabolic imaging in the US. Now it's been approved for that. So we'll cover a little bit more about the different radiotracers, but I want to draw your attention to the different half-lives at this time. So the main one is rubidium. The half-life is 76 seconds, so you cannot transport it. You have to have a generator next to you. With ammonia, it's about 10 minutes, so you can potentially transport it short distances. You can have it if you do it close by, if you have a cyclotron. And then O15 water is half-life 2 minutes, so you need to have a cyclotron by. Now for FDG, the half-life is about 2 hours, so you can transport it within the city and sometimes even longer distance by planes or others. The other thing we're going to talk about is the issue of uptake. So with uptake, the most linear one is O15 water. So you inject it, so you can have even a 50% lesion, which reduces the blood flow, let's say from 5 to 3. It will result in reduction in uptake or reduction in flow by O15 water. While the other ones, which are the more commonly used ones, N13 ammonia or rubidium or others, they have a roll-off effect, which Dr. Memanian also covered last week. So when you have that, you tend not to be able to see a drop in flow until you start to become into the more significant reduction in myocardial blood flow with significant lesions. Because so you cannot detect the difference of a lesion that reduces the flow from 5 to 3, but you might detect it if it goes from 3 to 1. So, and these are typically the more significant lesions there. The other important aspect has to do with the issue of the positron range. So to understand the positron range, we have to discuss the annihilation issue. So let's say you inject blood, it gets into the capillary of the myocardium, so it's now at this point. A positron is going to come out, and the positron will move for a distance until it reaches the point where it does an annihilation. With the annihilation, it gives the two 511 keV photons we talked about, which are 180 degrees apart. This distance between where the positron is released and the annihilation is called the positron range. And this one actually is different with the different radiotracers. So the higher energy ones, like rubidium, will travel longer distance before they annihilate, while the lower energy ones will travel lower. Now, as I showed you in the prior slides, when we get the randoms, we're going to assign them to this point. So although the rubidium or ammonia is in this spot here, technically we are assigning them to the point where the annihilation happened, and that distance is going to be some blur in the image. So the shorter the positron range, the better it is for the blur and the accuracy of the image. So the shorter this distance or the lower the energy, the better it is, and then it will allow you to be more accurate in your image resolution. And for this, I'm just going to show you the different positron range. They differ in terms of medium, but you can see here rubidium is kind of the worst one because it is in water, it has like 8.6 meters, versus O15 water is 4.14. Ammonia is much less, and the best one would be the F18 base agent. So any F18, FDG, or hopefully later on flurpiridaz will allow you to have much better in terms of positron range. It is much better in positron range, and it will be more accurate in terms of spatial resolution. So I'll show you here a couple images like ammonia versus rubidium. This is rubidium and this is ammonia, and you can see here that the differences on positron range will give you crisper images and better edge detection compared to what you see with, for example, the rubidium. Okay, so this is for the radio pharmaceuticals. Now we're going to move on to what do we do with these radiopharmaceuticals. So we can do multiple things with PET. Today I'm going to mainly focus on perfusion imaging. Throughout the year we will have dedicated lectures to talk about viability imaging, inflammatory cardiomyopathy imaging, and infections and endocarditis. So these topics I'm not going to cover today because they will be covered in more details in the future. Today I'm going to primarily focus on perfusion imaging. And with perfusion imaging, you can do it with ammonia, you can do it with rubidium, and you can do it with O15 water. But in the US, it's not approved for clinical use with O15 water. So the only two agents we use it clinically for is rubidium and N13 ammonia. So O15 water is the ideal flow tracer flow, but not for the entire myocardial perfusion imaging. Why is that? Because its extraction is linear. So as I showed you before, it is like almost linear in terms of uptake. You also it is the gold standard for comparing with other tracers, especially in the roll-off range. And also its half-life is 120, so it decays quickly and it very quickly redistributes because it's water. So that's why you cannot do more than just flow imaging. N13 ammonia is cyclotron produced, as I mentioned. The half-life is 9.8 minutes, almost 10 minutes. And you can inject it at rest and stress. So some sites do it with exercise, although it's a little bit more cumbersome with that. So it's not, but if you want to use it nowadays with anything with exercise, it will be ammonia. And then if you are using an older system, not the new digital system, which allows for newer tricks to do it, but the regular PET ammonia protocol needs a 50-minute difference between stress and rest to allow for the rest dose to decay before you go ahead and do the stress. But if you're doing it on the newer systems, then you can potentially use a high dose, low dose kind of approach for this. Now, most often you need a cyclotron for ammonia, which has to be close by, but there are now newer tools like on this kind of mini cyclotrons that is now FDA approved, and they'll allow you to go ahead and put it in a smaller room next to your machine, which allows you to get doses of ammonia. Now we're going to cover rubidium, what we use right now in our lab. And rubidium comes from strontium 82 generator, and we get it every 5 to 6 weeks. It's approved up to 7 weeks. And it has a 75-second half-life, so the generator has to be next to the machine. And the dosing is equal dose for rest and stress, but because it completely decays between the two doses, it depends on the system you have, which will determine how much you inject. So if you have a 2D system, like I discussed in the beginning, you need high doses, because many of the photons will not make it to the machines because of the septae. If you have a 3D system, then you can inject 25 to 30 millicuries. And if you have a digital PET scanner, then you can inject 10 to 20 millicuries. And you inject it over 30 seconds. There are different infusion systems that are available now. So rubidium is coming from strontium, and this applies to all of them. So you buy strontium and you put it in this injection system, one of these two that you have that come from the different companies, and now you get each month you don't change the entire injection system, or whenever every 4 to 6 weeks. You just change the generator, which you ship it and it's shipped to you, you put it inside, and now you can elute your system. These are the two commercially available FDA approved injector systems that are here and you can use to acquire images. And these are some PET images from our lab, and you can see here this is a patient with the rubidium images, and these are the F18 images. So you can see the effect of the positron range here. So here you see the images are a little bit thicker, a little bit blurred, while here you have much sharper delineation and more reflective of the wall thickness, as you see, and these are F18 images. There is a newer F18 agent for perfusion, which is not approved yet, but it is currently in phase 3 clinical trial, and we are participating in that trial. So if you have patients, and you can send them our way, we can enroll them in these trials, which are very important for perfusion imaging, hopefully. F18 agent, so now you're going to combine both. You're going to combine the lower positron range kind of characteristic with perfusion imaging. Right now we don't have an F18 agent, which is perfusion agent. We only have it for metabolism. So we're hoping that that will allow us to do perfusion with an F18 based agent. And here's one study where in the prior studies done by this agent will allow you to detect ischemia, which was not seen on SPECT imaging, and also will allow you to be certain about some findings where some studies were thought that there might be ischemia and there were none on Flopirida's F18 imaging. So we covered many of these points here. You can see that the images are good with rubidium, they're excellent with ammonia. You cannot interpret images with O15 water, so O15 water is primarily used for flow quantification, and F18 agents images are excellent. The FDA approval, as I mentioned, is primarily for perfusion, for rubidium and ammonia, and for metabolism for FDG. So how do we do this PET scanner? This is important for the fellows and the imaging fellows who are with us, and also for the general cardiology fellows who will rotate with us. So when you come and do this PET perfusion scan with us, so this is what we do. The patient will need to have a scout to identify where the heart is. Then you go ahead and do a transmission scan, which is the CT attenuation correction scan. Then we do an emission scan where we inject the radiotracer at rest and then later on at stress, and then get our image, and then we fuse both images later. So this is what we do: scout, transmission for attenuation correction, and then emission scan, which is the perfusion image. And then we fuse the images there. And we repeat it. We do it both at stress and rest. We don't repeat. Sometimes we need to repeat the scout, but most often we just repeat these two. So this is our protocol. Patient walks in, get a scout, then CT attenuation correction, and then the patient will go ahead and have the acquisition in the list mode. And then I'll explain in a bit what list mode is. Wait few seconds, inject regadenoson, inject the list mode in here, and then you can go ahead and do CT attenuation correction and calcium score. You can do calcium score at the end, or you can do it in the beginning. We are now injecting, because we have a digital PET scan, we are injecting 10 to 20 millicuries, but I put here the doses which are more commonly used in practice and using 3D systems, which are the 25 to 35 millicuries on the 3D systems. It's about a 20 to 30-minute procedure once the patient is on the table. If for whatever reason the patient cannot get regadenoson, you need to use adenosine. You do the same thing, but now you have to inject with maximal hyperemia. So you inject after 2 minutes of adenosine and then continue adenosine for 2 additional minutes. So you need to look at the logistics of injecting so you don't result in a bolus of adenosine and cause AV block. So that's why you need to have 2 IV lines, or if you have one of those lines where you have a 3-way where you can switch the 3-way to allow for injection without resulting in a push of adenosine from the tubing. And we covered some of these protocols with ammonia. The main difference with ammonia, if you don't have a digital PET and you cannot use the low dose, high dose protocol, then you have to wait 50 minutes in between. So the image acquisition is you can acquire data gated like what we do in SPECT. You can acquire it in static only if you sum the gated, or you can acquire it with dynamic. So dynamic and gated are very different. Or you can acquire in list mode, get the EKG gating, get the time data, and then later on separate the data. So if you say you want to acquire in gating, so you just turn on the EKG and you say every time this photon is coming to the machine, it's going to put it in a separate group based on the time it happens from the RR interval. We are using here 16 bins, but for simplicity I put here 8 bins. So if it happens at this time, the data will come to this bin. If it happens early on, then in relation to the RR, the computer will put the data in different bins. Or you can acquire in, so this is how the gated information will look like. So each data will look like, will be put in a different bin depending on where the data is coming in relation to the QRS. Now you can move on and acquire data based on perfusion, but it is important to also have the EKG data, because what you would like to know about the added value of this ejection fraction, importance of ejection fraction determination. With PET, we are getting the true peak ejection fraction. So this is not like in SPECT, where this one is acquired 45 minutes after the PET, after the stress test has happened. This is happening at the time that this patient is at stress. That's why the peak ejection fraction has important value compared to what you get with SPECT, where it is after like 45 minutes from there. And that's why we give it extra importance, because a 5% drop in ejection fraction has been suggested to be very concerning, both diagnostically, because it shows it is more associated with 3-vessel disease, or prognostically, because a more than 5% drop in ejection fraction is associated with worse outcome. In terms of accuracy, PET is probably the most accurate one, and this is even without including the flow data. And this is comparing PET to CMR to SPECT, where PET and CMR outperform SPECT, but still the most accurate one is PET imaging. And this has been confirmed also with PET and in the meta-analysis, where PET has higher accuracy compared to SPECT imaging, where the AUC is 0.95 versus 0.9. We'll skip this for quickly. So now we're moving on to the dynamic imaging. So the dynamic imaging, now we take into account not only the EKG, so the EKG is now on the side, we're not looking at it. Now we're just looking at it purely in terms of time. So we acquire the first 5 seconds, we put it in one bin. The second 5 seconds goes into another bin. So the movie that you'll see, the frame is primarily by time. So it will tell me where is rubidium now. So rubidium now is showing here. Rubidium now is showing into the right ventricle, then the left ventricle, because I'm just putting it by time. And each frame of this movie that you're seeing is different in timing in terms of the machine, on the machine. So the first ones are acquired over 5 seconds, then the second one is acquired over 10 seconds, then the third one is acquired over still 5s, and you do 10s, and you do 30 seconds, and the last one is acquired over 1 minute, because most of the rubidium have already decayed, and now my image is actually acquired over longer time to be able to get an image reconstructed. So once we get that dynamic imaging, we can draw regions of interest, measure how much blood made it to the heart, and how much blood to the LV cavity, and how much made it to the myocardium. And based on that, we just go ahead and draw this time activity curves and measure the myocardial blood flow that will allow us to get information about the flow, how much flow made it to the left ventricle and how much flow made it to the myocardium. So the first one is drawn here, where you see the curve here is the what we call the input function, or this is the time activity curve in the left ventricle. So all the blood or all the radiotracer made it to the heart, to the LV cavity, and then it just washed out of the LV cavity. The second one is here, this light blue is the myocardium, or the here, where you see here the myocardium actually is having the radiotracer sitting in the myocardium. So in summary, we can acquire we will get multiple sets of images. In SPECT, you're primarily getting the ungated and gated images. With PET, you're going to get the ungated or static. You're going to get the gated imaging, same principle as SPECT, but now we're adding the dynamic. And the dynamic takes into account from the time of injection all the way to later on. Now you can even do now in research tools and other newer tools respiratory gating, taking into account the motion of the patient and his respiration, and try to correct for that in terms of the motion to allow for even crisper images, and hopefully we're trying to see if that has any impact on diagnostic accuracy and myocardial blood flow. So another thing, because sometimes when you acquire the image, if you wait too little, the blood pool has not completely cleared from the rubidium. So there's still some rubidium in the blood pool. So usually, so this is what I've been taught, I mentioned here. The first one is that to be able to get the blood pool completely, you need to wait a little time between the time of injection to the time of the image that you're going to include in the static. Usually it's about 2 minutes, so the first 2 minutes you're not going to include them in the static image. They are extremely important for the dynamic imaging, but they are not important for the static image. In fact, you want the blood pool to be clear. So that's why if the fellow will look at this and see, well, there's still a lot of blood pool activity here, I'm just going to add an additional 30 seconds to clear it. And now you can see now you have less rubidium in the blood pool and sharper edge delineation, which will have more accurate volumes and ejection fraction. And we know that PET, when you take it into account in the Pacific study, and in the Pacific study they used O15 water. So technically all they had was just the dynamic data. They didn't have the static data, didn't have the ejection fraction data, did not have the TID or any other information you get from the rest of the images. So they just got the flow data, and that flow data alone was better than all the other comparators that were seen. It was the highest accuracy for detection of diagnosis of obstructive coronary disease. And that's why also when you have normal flows, it kind of rule out prevalence of obstructive coronary disease in the series. So they show that negative predictive value is 0.97. So technically a normal flow is associated with normal, no high-risk obstructive coronary disease defined as left main or three vessel disease in this series of nearly 200 patients. However, the only caveat I would say here, this is in all comers and obviously not so you have to take into account other information. So maybe the 3% that were missed are probably low ejection fraction or high calcium score and others. And we know also that this flow data adds incremental prognostic value. That's why you see it on our reports, and that's why we try to educate our referring physicians about it and what does it mean and how should it impact your management there. So where is it mostly helpful, this flow data? It is helpful among patients without prior history disease, where you are thinking of myocardial ischemia, so you see an area where the flow is reduced, then you are more even certain that there is true disease there. If you have those with non-CAD, but especially among looking at the other vessels, or if you want to see if there is microvascular dysfunction in some patients, it will also help us, and we'll share cases throughout the year where it helps us delineate multi-vessel disease, even among patients where there's only one-time perfusion defect. We look at if there are disparities between visual perfusion and normal angiography, if you're thinking for microvascular dysfunction, and finally among heart transplant patients if we're thinking about vasculopathy. Now, where it is a little bit more difficult to interpret among post-CABG patients because most of them have reduction in myocardial blood flow due to the extent of atherosclerosis they have. Among patients with large MIs in these territories, the flow is reduced, so the global number may be low. Also, among patients with chronic renal insufficiency for multiple reasons, because they have diffuse disease, but also these patients actually have fistulas, high cardiac output state, so the resting flow may be high too. And finally, among those with LV dysfunction, because the flow is reduced, partly because of the LV dysfunction that these patients have. And I want to finish up by this perfusion protocol that shows you the radiation doses of the perfusion protocols. So if you're using dual isotope, which we don't use anymore and we discourage its use, you're talking about 20 to 25 millisievert. If you have using a 2-day protocol, then you have nearly 10 to 15 millisievert. If you're using SPECT protocol with 1 day, then you're talking about 10 millisievert or so. Now, once you start to come down lower doses with stress only, but the lowest dose will be with rubidium and ammonia. So any PET protocol is, at least at this time, better than the stress protocol. And given the doses we're injecting with our machines now, with the digital PET, it allows us even to perform some studies with less than 1 millisievert, because we inject only 10 millicuries of rubidium with these. And looking at these, that's why the ASNC guidelines and recommendation, this is my last slide, tells you that among patients referred for myocardial perfusion imaging, the 2 checks that you have to do is the study appropriate. If yes, then you move on. Then the second one, do you have a comparable diagnostic study that without radiation? If yes, you can use that one. If not, then you can. The second question is, do you have PET? And if there is a PET, then you can go ahead and acquire using positron emission tomography rather than using SPECT, where you try now other tricks to lower radiation doses. So with this, I'm going to stop and start to take some questions. It looks like we're already receiving one of them here on the board. So it's asking about what's the difference between 3D and digital PET. So let me go up to the beginning of the slide set and I will show it to you. So the first thing about the 2D versus 3D. So 2D is, let me get, okay, this slide, if we can project it, yes. So 2D PET versus 3D PET is primarily related to the issue of the septate. In front of the detector, in front of the LSO detector, have these septae or not. If you have these septae, then it's a 2D system. And these are usually led to allow only one way kind of direction of the PET detectors, of the photons to get to the detector. While the 3D is septae, so both truths and randoms will make it. Now, the digital PET has to do beyond the detector, so it's not at the detector level, it's at a higher level. So it's mainly this photomultiplier 1, what happens in there. So beyond the detector, so this is the detector, if you have a septae in front of it or not. And if you have the septae, it's going to be. For the digital one, now you're talking about a photomultiplier, which is more digital. It's called the SPIM PMT, and this one will allow you now as a whole unit to have much higher sensitivity, and now you're able to detect, to amplify the signal you get from lower doses of rubidium. And technically, you're not even saturating in these patients unless you reach really very high doses of injection. Any other question? So, any question from the fellows? Try to make it more balanced between physics and clinical. We can discuss other physics principles in the reading sessions when we have more cases. Okay, any other question? So we'll wait for 30 seconds if anything comes up. All right, well, sounds like no more questions and we're gonna close this session. Thanks for attending and we look for next week for more sessions from our MMI conference. Thank you.